Hello, all my fitness, lifestyle, and specialist friends. We are in the home stretch, and I am so glad that I have got to at least be in touch with you guys in some way or another during this term, because I think I would have been even more sad if I hadn't actually been able to communicate with you guys or maybe see you on a couple of Zooms. Some of you I was able to see during your interviews. But I gotta say, I do miss you guys, and I'm just wanting us to try and keep motivations up as we are coming into the final home stretch. We've got 2 weeks of class left, and we can do this. I'm so excited to be able to finish out this term strong with you guys. So what I thought I would do is talk to you about some lumbo, pelvic, and hip complex issues that we have. So we have our hip here, and as far as the type of joint that it is a ball and socket joint, right? And the movements that it does, we've got a variety of movements that it does, such as flexion, extension, abduction and adduction, internal and external rotation. And then when we put all of those together, it also does circumduction. So that's a great perspective as far as it does all movements that we can do. The articulation between it is, remember, the head of the femur is coming in and connecting with the acetabulum or acetabolum, depending on how you want to pronounce it, found within that hip complex. And as far as our joint by joint goes, you are right in thinking that we are looking for mobility. Inherently, it's a pretty stable joint all on its own. However, we use it so much and there's so much contraction and so many muscles that are there that we end up having a lot of mobility issues with our hip itself. And then when we're looking at the lumbar spine, because we are going to include a little bit of information on that today, we're looking more for stability. So just kind of as we move throughout, we've been kind of working our way up the body, right? Starting with our ankles and then to our knees. Now we're at the hip, and then we'll start moving into the lumbar spine as well. Okay, so let's just do a little bit of anatomy review. What I would like you to do is to actually pause the video for a minute, and I want you to try and just do a long-term recall of looking at our anatomy, of our hip, and saying what muscles are they that lead to flexion of the hip versus extension of the hip. So go ahead and pause your video for just a moment and just brainstorm. See what you can come up with. Try it. Can you come up with just at least a couple or some of the primary movers? All right, I'm hoping you didn't cheat and you actually did pause and at least try to brainstorm. Here is what we've got. As far as flexion goes, we have the iliopsoas and the psoas major. Those are the ones that I'm hoping would come up to your mind right away. Those are the ones, the primary movers that we have there. We also have the sartorius, pectineus, rectus femoris, tensor fasciolata, adductors, the longus, the brevis, and the magnus, as well as the gracilis. For extension, I hope that you are thinking hamstrings and knowing that the biceps femoris, semitendinosus, and semimembranosus are contributing to the extension. And then as well as the glute max and the adductor magnus. Okay, so our next one then is adduction and abduction. So take a moment, pause the video. What can you come up with that does those different movements? All right, so for adduction, well, a lot of them have the name in there. So adductors, longus, brevis, and magnus, and then also the gracilis and the pectineus. For abduction, oh, I'm sorry, and the glute maximus, sometimes you'll find in different textbooks that the maximus does that as well. For abduction, we have the glute med and minimus, the sartorius and the tensor fascia lata. And then when the hip is flexed, we have the external rotators that will come in and also help with abduction, like the piriformis, obturator internus, gemellus superior and inferior. And then again, some of the fibers of the gluteus maximus are recorded to have abduction as well. Okay, so the last one for review, I want you to pause and try to brainstorm, what does internal rotation of the hip and what does external rotation of the hip? So for internal rotation, we have the glute medius and minimus and the tensor fascia lata. And then there's kind of some debate as far as whether the adductor magnus, pectineus, and gracilis help to contribute to that. It depends on which anatomy book you're looking in. Will determine whether those will differ on whether those are ones that are involved or not. For the external rotation, we have the gemellus superior and inferior, the obturator internus and externus, the piriformis, the quadratus femoris, the sartorius, and the glute maximus. So that's essentially our PGOGQ or GOGQ, and then our sartorius and glute maximus. Sometimes you will see that the pectineus also contributes. It depends on the anatomy source that you are looking it up in. Okay, so let's talk about some of our common impairments that we're going to have of the lumbar region into the hip region or the pelvic region. So the ones that we're going to take a look at is the pelvic sag, lower cross syndrome, the sacral crust fracture, some joint issues, bursitis, and sciatica. So you guys remember this from anatomy when we were looking at it and just looking at the hip placement and being able to identify weakness in some of our muscles based on how much hip displacement we have when there is walking that is happening. So here, remember, we had very dysfunctional movement in which when we're looking at a line that's going basically like straight down the femur towards the patella, compared to a line that's going across the two ASIS periods on the right and the left, and you have this acute angle right here versus more strength. Line's a little off there, but you can see that there's a lot of strength here in that this is more of like a right angle. And so this can be tested by having somebody stand, and the stance leg is the one that is affected. So if we have this pelvic sag where you can actually see her pelvis is swinging off to her left, you know, that you have, compare that, the ASIS or the iliac crests on the right versus the left, and you'll notice that the one on the right is considerably more dropped compared to the left. So she's not standing, and this isn't just like she's choosing to push her hip out. This is her trying to stand straight and what happens with her pelvic region. So this is an indication that our abductors are the ones that are significantly weaker, the abductors. So what could we do as far as corrective exercises? We want to work on abduction then of that hip. So I've showed videos in the past of the clamshells and the fire hydrants and the double leg bridges. Those are excellent ones for us to be able to be working on. We can also have our clients do a box walk, which you put a lateral, like just a band, a resistance loop or a band around the thighs, and have them push their hips back. And essentially we're doing just like lateral walking in a square type position. So you'll walk across laterally, and then you'll do like a high knee pickup to walk forward, and then you'll go across laterally the other side, and then a high knee coming back into the original starting position, and then move lateral again. Or you could literally just be going back and forth on a lateral line, and so you don't actually include the forward or backward motion at all. So that is one of our possibilities. Have them go slow and make sure hips are back and are in a really good position to be able to do this. Other ones is we could do the baby star. This is the regular star. So I'm just showing you kind of what the star exercise is. It is a good core exercise, but it also works on abduction as well of the hip. However, this move in itself is really only reserved for highly fit individuals. It's a lot harder of a move to keep your stability than what you would think it appears as. And so you'll see like a lot of trembling, you'll see a lot of compensations that are starting to happen with individuals who are doing a full out star. So we always start everybody on what's called the baby star. So it's the equivalent of it, except you are on your elbow with your shoulder right above it. And then this is kind of an in between baby star, because a lot of people actually put the knees down on the ground. So putting that bottom knee on the ground itself and just kind of resting on it and then going into that star position. The next level up would be the one of this picture of this male here where the leg is extended and it's but you're still on your elbow. And then you'll ultimately would end up progressing to get to the full star. But again, I said that's for advanced individuals. All right, so let's talk a little bit about lower cross syndrome. So we've already talked about it actually in the past, but we're going to address it again. And just looking at, we are flexion addicts. We are constantly sitting with our hips in flexion. And what that ultimately leads to is having tightened areas and then weaker areas. And it's in this crossed section of the X that you'll see these. So tightened areas tend to be the hip flexors, like the iliacus and psoas major, or the iliopsoas, and then the rectus femoris, tensor fascia lata, adductor brevis, and also on the back, the erector spinae tend to be tight, which means we end up having weakness on the cross points of that. So the rectus abdominis, the transversus abdominis, and the obliques, so looking at our abdominal muscles, and then the glutes, the maximus, medius, and minimus also tend to be weak. So this is like, you could almost say it's true of every person that exists out there, because we are all flexion addicts, right? And so we tend to have weaker cores, weaker glutes, tight quads, and tight lower back. So if we just thinking for a moment, okay? If we're losing hip mobility, what symptoms might they be presenting with, right? So what would we see with someone who is losing that hip mobility? Well, a lot of it can come back to what we were seeing with this lower cross syndrome, where we're having like a weaker core, they're unable to do things like that. We can have tightness in the hip flexors as well, or having lower back pain that could be contributing to this, right? And then when we also look at kind of just how this hip mobility issue plays in with other types of injuries and illnesses, when you have decreased hip mobility, you tend to have lack of stability in the lumbar spine. So that can manifest itself, as I said, in that back pain. You can also have a lack of stability and control at the knee. So you actually have some knee varus where it's coming in, like having, like your knees come together, or valgus, when the knees are going out during movement. And this is usually on the same side. So if you're having a hip issue on the right side with a lack of mobility, the knee on the same side, the ipsilateral knee, is the one that's often affected. And it can translate even into lack of mobility at the ankle on that same side. The reverse can actually happen as well. So if you have a lack of mobility at the ankle, it can also translate to a lack of stability and control at the same knee, and lack of hip mobility at the same hip. So if you've got a right ankle injury, potentially you could have some issues at the knee, or it might work its way back up to the hip itself. And then what happens is we get cross the body for the thoracic spine and shoulder tightness. So somebody who's been having issues on their right side, up all the way anywhere from the ankle to the knee to the hip, what we often see is a cross body sling of the fascia and literally the fascia crosses the body in an X towards the trunk, and you can have a lack of mobility in the thoracic spine more on that left side, or left shoulder injuries or shoulder tightness. So it's really interesting when we start looking at this joint by joint approach and realizing that when something happens with one joint or one area of the body, it can translate to all different areas. And so we need to be realized somebody might be coming in for having back pain, and maybe the back is not really what the issue is. It's actually having a lack of hip mobility, which is why we need to be performing our movement assessments on our clients to be able to figure out, okay, what are the issues that we're dealing with, and what can we start working on to try and fix some of the underlying issues. So we need to make sure we're managing symptoms throughout the whole body and not just focusing in on the one thing that happens to be giving them pain, right? Because it actually might be caused because of an injury somewhere else. So I'm just going to move my thing real quick. So what can lead to decreased hip mobility or hip stiffness? So what is it? Well, it could be a muscle imbalance or an overuse of muscles, such as, having excessive sitting all the time, being flexion addicts that we are. It could be joint instability. There could be issues with ligaments, tendons, or the joint capsule itself is weak or has a little bit of play in it or laxity in it. There could be some structural damage to bones that are involved. Could also be hypermobility of the lumbar spine, because remember, we do want the lumbar spine to be stable instead of mobile. So if we have too much movement in the spine. So taking a look at our muscle imbalances or overuse. So these are the things that we're going to notice, that having tight hip flexors, tight hamstrings. So we'll need to work on lengthening and rolling or inhibiting those. And then we tend to have more of the weak upper and middle back. So just trying to make sure we're balancing that out as well. So overuse and tightness versus underuse and weakness. So finding out, what are we dealing with? How are we going to function with this? What do we need to treat? Finding out what is tight, what is underused. And a lot of this is going to come through movement assessments that we've already been looking at to guide us in these decision makers. So some muscles inhibit others inherently. When we are having our adductors and our psoas tight, they tend to inhibit the glutes. So we're talking about that antagonist. We have that inhibition that's happening automatically, right? That we learned about a couple of weeks ago, in that if one is constantly activated, other muscles will end up relaxing in order for there to be that contraction. There can also be issues like misalignments of the hips, structural damage to muscles, inflammation, and whatnot. So there's a lot of different other things that can come into play as well. But the question is, like, if there is muscle imbalance, and that's the main problem that we're having, what do we need to do? Well, we need to go in and we need to lengthen and inhibit all those tight muscles, and we need to activate and start building strength with integration in those underused or weaker muscles. So now that was the muscle use. Now let's take a look at joint instability that we can have. So things like labral tear, a ligament or a tendon tear or strain, hyperlaxity in the ligaments, which is usually due to like high levels of progesterone, which is a hormone, a female sex hormone that actually leads to a lot of laxity in ligaments. And it could be weak stabilizing muscles are causing the instability as well. So if ligaments or tendons are not providing the adequate stability, the muscles will need to tighten as they try to create that stability, right? So it's gonna, if there's laxity and lack of that stability at the joint, the muscles are gonna tighten and it's gonna lead to that stiffness. Looking at a labral tear, the symptoms that we'll see is that there's weakness in the hip, instability, that the individual can actually feel it catching or clicking. What you can see down in the corner in pictures A and B, they're often holding their hip with their hand in a C shape. so it's called a C sign, where they'll make a C with their hand on the affected side, and they kind of just like hold it right around the hip area because it helps to bring that stability that is not there because the labrum is torn. So as far as the diagnosis goes, what they'll do is they'll take them in and get a scan and use an arthrogram, which injects a contrast dye for them to actually take a look at the continuity of the labrum. And so they'll look around in the labrum. You can see it highlighted in the white in this x-ray picture that we have here. And the arrows are pointing to an area that it's actually weakened or torn right there in that area. So that's how they'll actually diagnose it. As far as treatment goes, physical therapy of doing strengthening, mobility, motor control exercises. They'll put them on anti-inflammatories if there's a lot of inflammation in the area. And then they'll try to do some trigger point therapy on the soft tissue and trying to relax some of the tightness that's there. They might even do like injections of hydrocortisone or such. And then in last case scenarios, they potentially could be doing surgeries to repair the labrum as well. So a lot of people have labral tears and they don't even know that they have them, and they don't require treatment. So it's kind of unclear as far as, you know, what we should be doing. Like, do we need to treat them? Do we not? So a lot of the times that it's trying to figure out how much is it impeding the person. And then a lot of other injuries will actually resemble signs and symptoms of what we have of labral tears. So we always need to make sure that that's actually what the issue is before we try to treat it. If we're having ligament laxity and weakness, the muscles are trying to create that stability, remember. This can be caused because of genetic, hormonal, or it could be due to an injury. And so really we need to start strengthening the stabilizing muscles across the whole chain, right? So not just at that one area of the hip, but actually all across the different areas of the body to build on the core strength as well. There are some nutritional interventions that sometimes can be recommended, like an anti-inflammatory diet using things like proteolytic enzymes. You can find those in like pineapple and papaya, or eating larger amounts of zinc found like in seafood and nuts. And then vitamin C can also help to keep the integrity of the ligaments and such, so like kale and oranges. Sometimes issues in the hips is actually structural damage to the bone. So here in this picture, what we're looking at here is a sacral stress fracture. You could also have a femoral stress fracture of, you know, of the femur that we have there. As far as the sacral stress fracture, the signs and symptoms that you're going to see is like pain, a limp perhaps, inability to bear weight on that side. So it causes pain when we're trying to bear weight on that leg. There could be weakness and then also tightness in the area. The only way really to diagnose this would be to do like an x-ray or an MRI. And then as far as the treatment goes, especially if it's a structural, like a sacral stress fracture, it's kind of like you just rest and you unload it. And then you can try to like heal the body in other ways, like through nutrition or sometimes by changing the hormone profile. That if it was a hormone imbalance that caused that fracture, we want to correct for that as we go through. Another lumbar issue that we can have is hypermobility. So symptoms would just be pain, tightness of the hip or sometimes the back. And sometimes you can get some neurological nerve pain because if it's mobile and it starts to actually pinch in because of the movement on those spinal nerves that are coming out through the intervertebral foramen, you can actually get some pain in the nerves as well. So it could be because of ligament issues, muscle issues. We also have just the degradation of the bone itself. Um, Also facet joint degeneration. So where the facets are coming together for the vertebrae, there might be some degeneration there. So the diagnosis, they do a clinical assessment and they'll do an MRI to take a look at it. And then usually the treatment is physical therapy or chiropractics, and then doing like a lot of strengthening and stability, and doing training for good movement and making sure the movement is good, proper technique. For the patterns, and making sure that we have good patterns. Usually it is not treated through injections or surgery though. So just taking a look at that facet joint syndrome that you can see here. So the pars degradation that we have, you can basically see this, the spinal processes are coming together more than they should be on the lumbar vertebrae, and it can actually cause a breaking off of it and actually a separation of it. And then that can lead to a lot of inflammation that's happening in the area and can start to damage the disc as well. So symptoms that we're seeing: pain, tightness, which they might be like guarding their muscles or guarding with their muscles to kind of protect the area. And sometimes, again, as I was saying, like we've got spinal nerves that are coming out in this area, so we could have some nerve pain that's happening as well. Causes are because of instability due to ligaments or the muscles. There are also some just genetic abnormalities that can happen, which is where it just makes it more prone for us to be having this pars defect right here, which ultimately can lead to this spondylosis. And then poor movement patterns or having repeated stress that is in the wrong areas of the vertebrae and such. Diagnosis, clinical assessment, they'll do an MRI as well, and then treatment is usually physical therapy or chiropractics, strengthening and stabilizing all of the area, training for those good movement patterns. Injections can help with this, especially if we're having a lot of inflammation in the area, and sometimes surgery is required for it. Just the last couple that we have here. Bursitis is when we have inflammation of the bursa. So remember, the bursa are just these fluid-filled sacs that act as shock absorbers in certain areas. We have them in our shoulders, we have them in our elbows and our knees, and also in our hips. So we have the one that usually causes the most amount of problems would be the trochanteric bursa. That's the most common one that you hear of. But we also have an iliopsoas bursa, glute medius bursa, and an ischio-gluteal bursa as well. So as far as bursa and what you're feeling, you'll get pain in the area, a lot of tightness. Usually you don't have like radiating pain of nerves in that. It's just local in that area typically. Causes are because the muscles are tight in that area, and there's a lot of use. So the tendons are running over these bursa, and it's causing a lot of inflammation in that area because of this overuse, repeated activity. Sometimes they can be they can come on because of hip injuries themselves or having recent surgery on the hip. They can diagnose them through a clinical assessment and doing an MRI to take a look at the inflammation in the area. And then the treatment, they'll do physical therapy, they'll work on some mobility of the hip, and then improving movement patterns and strength all the way up and down the chain, just to try and take some of the bad movement patterns away from the hip itself. We can do a lot of anti-inflammatories here, because really the inflammation is what's causing the pain and causing the issues. And so they'll actually inject with hydrocortisone, with a cortisone shot to go into that bursa itself and just shrink the blood flow to that area and decrease that inflammation. And we do find that sitting actually instigates more pain with, like, especially a trochanteric bursa, bursitis. And so trying to get them to stand more can just help to relieve that pain instead of like sitting in cars or planes for long periods of time. And then the last one we have is sciatica. So sciatica is we have that radiation of the pain that is coming through the sciatic nerve, which travels down behind the femur, coming out right in between the piriformes and our gemellus superior that we have. Sometimes it actually sometimes the piriformes is actually bisected by the sciatic nerve, in which it actually comes out in the middle of the muscle, and those individuals definitely can suffer from sciatica because of that. So pain, numbness, tingling, sometimes there's weakness in that leg. Possible causes could be some disc slippage, the spinal malalignment, if we just like the spinal column is not lined up. We could have cysts on the facet joints. If the piriformes is actually too tight, it can put a lot of pressure on that sciatic nerve. Or if some of the hamstring tendons that are coming in and attaching to the ischial tuberosity can become tight and can compress on that nerve as well. So they'll look at it through a clinical assessment, they'll take an MRI, and perhaps even do a nerve conduction study to find out like where could the blockages potentially be coming from. Treatment will be physical therapy, chiropractics to kind of align things back into their right position, work on a lot of mobility exercises, improve movement patterns and strength in the area if needed because of inflammation, like in the piriformes or around the tendons of the hamstrings. They'll go in and do some injections, like a cortisone injection, or put a course of anti-inflammatories on board. And again, this is aggravated more by sitting. Occasionally surgery is needed, but it's kind of rare as we go. So that finishes up our hip and lumbar pelvic region. And so that is it for this topic. And we just got a couple more to go before we finish out the rest of the term. And I hope you guys are having a really good day.